I'm your host, Dr. Ronald Yap, and this is our very first show. And the purpose of the show is to try to educate the world about men's health issues. And when we get it out there, please give us your comments and thoughts. And I hope to make a whole bunch of these with a bunch of interesting colleagues we have in the medical community. So today, the first show will be talking about prostate cancer. And this is a very important subject. It's the most common non-skin cancer in men. 1 in 7 men will be diagnosed in his lifetime. African Americans, 1 in 5. And if you have a family history, it's 1 in 3. There are about 181 new cases of prostate cancer that will be diagnosed this year. And about 27,000 men will die from this disease. So it's a big affliction for men. Today, I have Dr. Tom Sheldon, radiation oncologist at Concord Hospital, who will be joining me. A couple words about Dr. Sheldon. He's a Bachelor of Science in Biochemistry at University of Wisconsin-Madison, Tufts Medical School for his medical doctorate, and went to the Harvard Medical School at the Joint Center for Radiation Therapy. He has extensive clinical experience, especially with brachytherapy or seed therapy for prostate cancer and radiation therapy for prostate cancer. Also a very extensive career as advocacy representative. You didn't think I was going to do this, did you?
No.
So serving as the New Hampshire president for the American Cancer Society and also on the National Board of Directors. For these efforts, he received the prestigious St. George's Medal. So welcome, Dr. Sheldon.
Thank you. Thank you for having me, Ron.
No sweat, no sweat.
Yeah, it's great to see you outside of the hospital and outside of the OR.
Yeah, thank you for doing so. This is our inaugural show.
Right.
So thanks for being a good sport. I can't think of a better person to start it with me.
Yeah.
You're used to performing in front of tons of people in the orchestra, and this is a different kind of crowd.
Very different, yeah.
And we've been working, I brought you here because also we've been working together for 10 years over patients for prostate cancer, and have helped a lot of people. And in addition to your resume being very impressive, you're just an all-around good guy.
Right.
So, but yeah, no problem. So the first thought I had is that just being in Concord Hospital for so long, the story of how, Concord Hospital started with the Payson Center and bringing radiotherapy services here, I don't think a lot of people know about that in the community. And we kind of, I don't say we take it for granted, but when I diagnose someone for prostate cancer, I say, unfortunately, sir, you have prostate cancer. Go see Dr. Sheldon. He'll take care of you. So if you can, give me a few words about bringing radiation services here to Concord Hospital. Tell me a bit about your journey.
Sure. I mean, it was a long journey. After I finished my residency at Harvard, I stayed on faculty for a while until I moved to New Hampshire. So I really only had 2 jobs. We started at the Elliott Hospital, and that was in 1986 that I came to Elliott Hospital. In 1989, I joined the staff of Concord Hospital, so that's how long I've been on staff. And in those days, we didn't have radiation therapy or medical oncology on site, but we would come every week to something called tumor board. And the new cases of cancer would be presented at tumor board. We'd go over the x-rays, we'd go over the pathology, all of the specialists would be there, all the surgeons would be there. And we'd try to, as a group, make a decision on how best that individual patient was treated. But it was also an education session. And it was not only for the non-oncologists, but we would, Concord Hospital has always had a great surgical tradition. And so I would learn a ton from talking to the surgeons, talking to the urologists. It was a wonderful process. And for many years, Elliott was the closest place for radiation oncology. What happens is the state has a CON law process where you have to be able to demonstrate a certain volume. And it took a lot of years for Concord to have enough volume to get permission for a unit. Finally it did, and we built the Payson Center. I was very involved from day one. It was fun. I actually got to look at the architectural drawings and such. I was very involved in how the clinic was set up. By that time, I'd been involved in starting new departments at Wentworth Douglas Hospital and at the Nashua Regional Cancer Center. And so, I had some experience designing departments, knew about the flow and such, and so I spent a lot of time with them deciding how best to set up that department so that we would have good patient flow, so that the nurses could really assess patients and such. But ultimately then in 2003, we put in our first machine. Mike Green was very smart in that he put in 2 vaults from the beginning, because Mike Green could see that the service was going to grow quickly, and that's exactly what happened. So in 2003 we opened,
Sorry to interrupt you, but for people that in the audience, so Mike Green's the CEO of the hospital.
Sure.
And we know him as Mike.
Yeah.
But he retired, well-revered CEO of the hospital.
Right.
And big impetus.
Huge.
Sorry to interrupt you.
No, but it was his vision.
Yeah.
I would say the patient center was Mike Green's vision, and so we grew very quickly. We opened and grew very quickly. We ended up needing a second machine very quickly, and we've been able to just continue to grow the service and continue to grow the quality to the point where we wore out one of our machines and just got a new one. And I think that's one of the important things we should talk about tonight.
I'm glad you're bringing that up, because this has been a very, very big push for the hospital. We call it the LINAC project, or the next linear accelerator, because these linear accelerators are very sophisticated pieces of equipment, and I think over the time that you're describing, it's become a major resource, not just for Concord, but I'm talking about the whole region. And some of the stats on that, it looks like at least 50% of our patients do come from outside the region even. And as these machines evolve and wear and tear, and technology does evolve, because it sounds like, about 10 years or so on these machines that the whole LINAC project started, with the Concord Hospital Trust. So give me a few words about this project, because we just had the grand opening and wonderful words from everybody about it.
Yeah, it was tremendous. I mean, the Concord community came together. The Concord Trust was able to raise a tremendous amount of money toward this machine. The final price tag was $3.7 million. Wow. So these are very expensive pieces of equipment. And the good spirit I get from the community members who donated, and just the support we've had has been absolutely tremendous. I can't say enough about it.
Yeah, and there were many lead donations from the community, and a special shout out goes to the Demoulas family that gave a very substantial lead gift, helped get the ball rolling, and many, many other people. So hats off to everybody, and we had the grand opening. Is it active now? It's
active. It's been active for a few months now. And the thing that's important to understand, so the linear accelerator is the radiation machine that everybody gets treated on. And there's a lot of the technology that's evolutionary. It just keeps getting better and better. We keep subtly improving the quality of care. And then there are other things that are really revolutionary. And I think people always want to hear about the revolutionary things. So this machine has a couple of things that we haven't had before. One of the most interesting is called a robotic table. So a patient getting treated lays on a table, which in the past has kind of just gone up and down, left and right, in and out. But what often can happen is when we're trying to set up things with millimeter accuracy, when we're trying to treat a tumor, let's say, right around the eye, if a patient, even if they're in an immobilization mask, if their head is rotated ever so slightly, it can pull their eye right into the field. Or if they go the other way, pull the target right out of the field. And what the new robotic table has is what any pilot knows about is roll, pitch, and yaw. So roll, if you're laying on the table and your head is fixed like this, roll means literally being able to roll the table, angle it like this. Pitch means going down and up, and then yaw means going this way. And we can do just a few degrees or a few centimeters of this adjustment to lock in precision such that we can have just millimeter precision in our daily setups. And that's important because we never miss. In radiation oncology, we never miss. And so if we have immobilization technology where the patient isn't perfectly still, or we have daily setup technology where we can't quite make these fine adjustments, we have to make our radiation fields bigger. We have to treat a bigger area, more normal tissue, more late effects from treatment. As we get more accurate in setup and as we get better in immobilizing every single day, we can shrink our radiation fields. What that allows us to do is two things simultaneously. One is to get off the normal tissues. But the other is because we're off the normal tissues, we can increase the dose to the target. Mm-hmm. And this is where I think in prostate cancer, which is something you and I deal with.
Yeah, let's bring it back to the prostate,
yeah, where it's been so important because our ability with new technology to not only decrease the risk, the dose to the critical organs, which in the case of prostate cancer are the bladder and the rectum. They get most of the radiation, non-target radiation. But we can not only decrease those doses, but have been able to simultaneously increase the dose to the prostate, to the target. And as a result, In the past 10 years, cures have gone up. At the same time, the complications have gone down. It's been a startling change in what we're able to do.
And I hear you the whole time. The needle keeps moving, and the tolerances are getting a lot better, and especially with IMRT,
Right.
intensity modulation. And the one thing that's very good about bringing up, I think the elephant in the room whenever we talk about prostate cancer, is the whole screening thing. And we're not going to go into screening. It's only a 30-minute show, and it's the first show, so I can't do all of men's health in one show, but we'll keep coming back to it, is that any way you can reduce toxicity in treating somebody for prostate cancer, the better we can treat these guys.
Absolutely.
And like I said, the screening issue will be separate, but I can tell you that without a doubt, like I said with the statistics, it's the #1 cancer in men, and it kills a lot of guys. And we have the screening controversy, meaning that a lot of people get screened, and there are a lot of false positives with the PSA test, and a lot of people get treated quote-unquote needlessly. But at the same time, how do you reconcile that with a lot of guys are dying? And I think, bringing you here and talking about the radiotherapy approach, and also I think we have a couple minutes to talk about the SEEDS approach as well. So just to educate the audience, nowadays the main treatments for prostate cancer would be surveillance strategies, either active surveillance where you're monitoring the tissue and doing PSA draws, watchful waiting where you're doing exams and monitoring PSAs but not doing as many intensive biopsy type procedures, surgery with removal of the prostate, or external beam radiation, and prostate seed therapy. I haven't talked much about the other more exotic approaches like cryotherapy, and even Tom knows we all the time hit up about proton beam and HIFU, and we're not saying they're terrible, but they haven't been in the mainline treatments. But clearly, if you talk to people out there on the street, you're really talking about either surgery, external beam radiation, or seed therapy.
Right.
So we had a bit of a discussion on external beam, and we could bring you back another day just to talk about that part.
Sure.
But I know one thing that brought you here with me as the first guest, is that we work so much together. And I think the nice thing about Concord is that you and I are sitting at the same table, and maybe we should just talk about that for a few minutes, because I don't know if you go to most places that you can get a radiation oncologist, 7 o'clock on a weekday, to come and talk to a urologist and work together over patients, What are your thoughts about that
relationship? Well, every 2 weeks we have a GU tumor board, and we sit down and we talk about the new cases, especially the prostate cases.
Yeah.
And you would think that every case is the same, but as you get into treating these patients, every single patient is different than every other.
Yep.
And the nuances of how to manage them is a very complex, from our standpoint, recommendation, and a very complex decision for the patient. And so one of our jobs, before we try to do it before we meet with the patient, is to get together and try to figure out what we think is best, what we make sense, what for us makes sense. And sometimes that's one option, sometimes that's two options, sometimes that's three options. But once we can decide in our minds what's best, then we can really accurately counsel the patient and give them a consistent message so they don't get confused.
Yeah, absolutely. And I think in the end, too, it depends on what the patient wants.
Right.
Because
Absolutely.
there's a lot of ways to skin a cat, and I think that's the funny thing about all these screening guidelines, is that when the United States Preventative Services Task Force went out and said, you shouldn't screen anybody, grade D recommendation means they don't recommend it at all. I think it's almost like, when we have tumor boards, every patient is different.
Yeah.
Who is African American, who has the family history, who has just a personal interest in being screened, you can't just block that guy out,
Of course, yeah.
And I think that for every patient, some people, psychologically want the gland out, and nothing wrong with that. And then some people say surgery is the last thing I ever want.
Right.
And we present that to the patient. And for the selected patients that are good candidates, and I think the nice thing about it is that you look at it from the radiation oncologist, and I look at it from the urologist end. For the seed part of it, I think we work great together. And I guess for the right kind of patient, any thoughts on your mind about who a good candidate is for seed therapy? Or?
Well, and let me just take a step back here,
Yeah.
because it's pretty interesting story how seeds came to New Hampshire. So prostate seed brachytherapy was developed in Seattle. A urologist came from Scandinavia who was an expert in ultrasound, and they figured out an accurate way to put radioactive seeds into the prostate. And accuracy is key here. And once they figured it out and developed some initial programs, the success came very quickly. my partner Jim Becht and I, before any of the major centers in Boston were doing it, we went out to Seattle and we brought prostate seed brachytherapy to New Hampshire. So Mass General wasn't doing it, the Brigham wasn't doing it, Tufts wasn't doing it, none of the major, BU wasn't doing it, none of the major centers. But in New Hampshire, we started because we could see the value of this, and it's only gotten better. We're just so excited about this program. It's a very selective group of patients, so as Ron knows, we have to consider very carefully who we want to implant. But when somebody's a good candidate, the success rate is remarkable, and the complication rate is very low. It's, especially sexual function is really excellent with prostate seed brachytherapy. And I'll finally say that the patients just keep telling us this over and over again. So
I think it depends on the patient too, because like I mentioned, there is some morbidity or downtime from surgery. And there is some advantages to the surgery in the sense that it's out and you can do lymph nodes. And the thing I love working about, with you and your partners is that we share patients all the time. And I would say, hey, get an opinion from Dr. Sheldon. If you think they need surgery, you send them right back.
Yeah.
And I don't know if you were in a major metropolitan area, if you
That
throw them in the
doesn't
black
happen.
box. I would say if you send somebody to radiation oncology, he's probably going to zap them.
It doesn't happen. And the other thing that happens, which I think is really amazing, is occasionally we'll have a case and there's 2 surgeons in your group that do the prostatectomies. And sometimes the surgeon thinks radiation may be a better option, and I'll think surgery is a better option.
Sure, it's almost
and
like you
we'll
go the
be
other
kind of
way.
going the other way.
Yeah.
And that's yeah.
But that's the responsibility. I think in today's world, I think we're eventually getting to a value-driven world for value in healthcare, but it's fee-for-service right now, which means, unfortunately, we get paid to do stuff. So I guess the default is that if you could do something, you'd do it, but we are the opposite.
Right.
And the one thing about the seed therapy, getting back to that, is that you look at it in your doses and morbidity and certain complications, and I look at it in the urinary department. So a lot of guys are older and they have BPH or benign enlargement of the prostate, or enlarged prostate as a man gets older. So I'll screen them for those symptoms, and there may be something I'm looking at and I'm like, I don't know about the seeds, maybe we should do something else, or you'll notice something. I remember we shared a patient recently that had some bowel issues, and I said, well, see Dr. Sheldon, he'll take care of you. I'm like, oh, bowel issues,
Yeah.
Like, yeah,
That's a problem.
that's a no-go, and then we rethought of things. So, one thing, you want to talk a bit about doing the seeds? Like
Sure.
what happens in the OR? Because that's very unique,
That
actually.
is unique. The other thing, I just would say one other thing at the outset, too, that I think is so interesting to me, having worked in an academic center in Boston and a faculty member, and then coming to clinical practice in the community, that one of the real differences is, for me, is number one, when I was at Harvard, I spent most of my time, teaching residents, lecturing, writing papers, especially writing book chapters. And I won't say patient care was an afterthought, but it was the minority of my time. Now, my only job is to make sure that each patient gets the best possible treatment.
Sure.
And I must say, I enjoy it so much more, but I also do it so much better.
Yeah,
and
I
I don't
hear
have
you.
residents, you're not getting treated by a resident, you're getting treated by an experienced person.
I think the pendulum's
And-
swinging the other way,
but-
too. Yeah, absolutely.
But the other thing I think that's interesting about community medicine is that we live in the community with our patients. And so I think we think about cancer outcomes, which they do at academic centers, but I also think we think harder about complications and clinical outcomes because we live with our patients.
I get it.
And we want to treat our patients like we would want to be treated. They're our community members. And so I think it really is a better feeling to treat patients in the community.
Yeah, and 2 thoughts on that is that certainly, I guess, if you're going to be seeing that guy at the store or at the hardware store or something like that, you have to account for what you're doing to them. And so it's really great to be involved with patients in the community and take care of them. And longitudinally, one thing I loved about urology is that we take care of people forever. We take care of them, and we see them. And what I like about working with you on the seeds is that you and I are in there together.
Right.
And I think what's unique about the way we do is really that collaboration. Not only we invest in the community, if you get a phone call, you can actually talk to your doctor, is that we collaborate on things. And there's so many things that are very nuanced. When we have a patient asleep, we're both in there doing it. And I don't know if, actually not many places do that. I know unnamed facilities, and I won't incriminate anybody, but I've heard, quote unquote, that the radiation oncologists at other places do the implant, and they just call the urologist at the end and they say, we're done, check out everything, and hopefully we didn't screw something up, and we're there together. And I like that internal check, because there's so many times when we're in there putting these pellets in, you have to be very precise. And the one thing about you guys doing this is that each one is molded. And I have this joke when I talk to the patients that I say that you're the architect and I'm the surly contractor, meaning you look at the volumes when a patient goes to sleep. You know, your team's in there looking at things and setting up each seat individually, and you and I are in there. I'm trying my hardest to get it in there exactly the way you want to, so the patient gets the best outcome. But you and I are talking the whole time.
Right.
You know,
And
I think
our knowledge is complementary.
Yeah. Oh,
You
yeah.
know, I don't think a urologist should do it alone, and I don't think a radiation oncologist should do it alone. I think together we just do it better.
It's a unique perspective, and I think you have a very keen eye for the dosimetry and what's what. And
that's because I've done over 1,000 of them.
Yeah, you know, it's
done so
it's
many.
great. That's cool. And I'm a young whippersnapper, but we've done at least 100, 150, 200 together, and you know, it's scary because when you mentioned starting this whole thing up, I think I could have been in grade school, buddy. So, but it's okay. My hands don't shake. Nope. Put those pellets in right. But the other thing too is that having the surgeon's involvement is helpful, because I've physically touched prostates, I've seen prostates, I've taken out prostates, and I specialize in laser prostate surgery too. So I've operated on prostates in other ways, and that perspective is really helpful. So it's been a good conversation today.
Yeah, maybe what we should do, you know, a lot of this was kind of introductory. But I think I'd love to come back, and maybe what we should do next time is talk about when I meet with a patient, and when you meet with a patient, what we tell them. You know, what is the reason for doing this procedure over another? What are the side effects and risks? And then we can really go through, you know, what happens in the OR and how it all works. I think people would find that pretty interesting.
Well, I love having more material, because we're just getting this thing going.
I know.
So I'm not looking for feeder material yet, but so anyway, I think this has been a good session. So thanks for joining me today.
You bet.
I hope to keep making more of these shows. So I'm still working with Concord TV. So first of all, Chris Gentry, awesome job. He's running the console back there, and he's really been a great assistant. Doris Ballard, Concord TV, getting this going. And the hope is that we get this out to the community, but I want to syndicate this out to social media networks, and hopefully you'll have comments. Hopefully they won't be lewd, because I've seen I've seen stuff on there, but what people will say about anything, you know. But be kind, and drop some comments and thoughts, because I have a whole list of people, and I think this is a message that has to get out there, because Concord Hospital is such a great resource. I'm so convinced that we do as good a job, if not better, than the academic centers. We just got to tell our story, man. You know. So thanks a lot, bud.
You bet.
All right,
Great
man.
to see you.
Yeah.
All right.